Good evening, and want to welcome everybody. Thanks a lot for joining us. Tonight we're going to have a discussion about COVID-19. We have a true expert with us tonight, and we're very fortunate to have him. But before we get started on that, I'd like to say a few quick thank yous. First of all, I'd like to thank our team behind the cameras here. We have Sean Macking and Corey Hall making the technical side of this possible. So very grateful to them for enabling us to do this. I want to thank our immediate past Commodore, Michael Blacker. His leadership during these tough times has been incredible, and he's allowed us to make some very good decisions. He implemented and activated a coronavirus control committee, which has put in place some very good protocols which have helped keep hundreds of members, guests, and employees safe. Our COVID control committee has consisted of volunteers. We have Jody Abrams, Kathy Ahern, Chris Nelson, Elisa Linsky, Paul Danielson, and Kristen Danielson. So I want to especially thank all of them. Also, the official chairman of our COVID control committee is John Sinnott, who is our esteemed guest here tonight. I want to thank our general manager, Mark Radams, and his great staff for complying with all the demands that the committee has put in place to help keep the members safe. I've heard from numerous members that the St. Pete Yacht Club is the only place in town they feel comfortable coming to eat or hang out with friends, and so we're very grateful to the staff who's made this possible. I want to especially thank George Pennington, who introduced and recruited our guest to the Yacht Club. Without George, we wouldn't have him here as a member. Our guest, John Sinnott, is an infectious disease specialist at the University of South Florida College of Medicine. He's also a teacher at that institution. He's such a great teacher, in fact, that he's won the Best Teacher award so many times in a row that they actually had to retire the award, and they just decided to name it after him. So the award is now the John T. Sinnott Award for Outstanding Teaching. He's an infectious disease specialist. He's the chairman of internal medicine at the University of South Florida College of Medicine. He's the director of the Florida Infectious Disease Institute. He's led numerous task forces under numerous governors in the state of Florida to reduce the risk of infection spreading in our community and around the country at the federal level. He's also worked as an international ambassador to Asia to help control SARS epidemics there in the past, and has led efforts to control other outbreaks, including Ebola virus. So we have somebody who has seen this type of infection before and has great experience in helping to control it in the past. He's a St. Pete Yacht Club member. He's the chairman of the COVID control committee. He's toured our facility. He's met with our management and our leadership to help implement protocol which have helped keep our members, our guests, our families safe. He's used his own boat as a medical support boat to our regatta to Havana, and he's a great doctor, a great teacher, and an even better friend. So I want to especially thank Dr. Sinnott for joining us tonight. It's a huge honor to have you here.
Thank you.
I want to remind everybody who's looking at this through the camera that he and I are actually much farther apart than we appear. We have a split screen that makes us look close, but we're not wearing our masks at this time, because we are very far apart. So what I'd like to do, I have been given a lot of interesting questions from members, and I'd like to try to put those together and help our members and anyone else who's out there viewing this learn a lot, as much as possible tonight. But I'd like to start by just asking you Dr. Sinnott, how do you feel we're doing as a society right now when it comes to the coronavirus pandemic?
I'm troubled and scared. I think that we need a uniform federal response, and it needs to energize the population into to fight a global problem. This is not just the U.S. This is everybody. And as we work on that, if we work as a universal team, we'll have a vaccine more quickly, we'll have medication more quickly. It's to our advantage to do that. For the moment, I worry about the fall and the meeting of influenza and COVID, two with similar symptoms at the same time of year, and that's going to be very hard for healthcare workers and for our population.
When it comes to the fall and the fact that we're coming into flu season and that the symptoms of the influenza virus and the virus that causes COVID-19 can have so much overlap, how can a person know which illness they have and whether they should seek treatment or testing?
Influenza is a serious systemic disease. It increases the risk for heart attack, blood clots, and strokes. It is contagious, and it's similar in symptoms to COVID. COVID is a new virus. Its initial disease-causing capacity is due to disruption of blood clotting. So you get blood clots in the heart or the brain or the lung. And the second phase is more immune-mediated, where you have lung disease. It would be very hard without laboratory testing to tell the two illnesses apart.
What can we do to protect ourselves, to reduce the risk of contracting these illnesses?
I think that's an important question. I think that in this instance, we need to think not about a 2% mortality rate, but the possibility of a 10% complication rate, okay? And these complications that I've seen firsthand with its close cousin SARS in China, 15% of people ended up with severe lung disease afterwards. 12% needed one or both hips replaced. 8% had a neuromuscular weakness syndrome. We're starting to see that now, and in an article out of Japan, they showed that at 90 days, a lot of people weren't better. And when you talk to people, they're not recovering as quickly as we'd like. And there's also not a good correlation between severity of illness and delayed effects. So cardiac disease and cardiac complications are every bit as common with mild disease as they are with severe disease. So it's a new disease we're learning about, and the long-term effects could really be a problem. And this is the big argument against herd immunity that we hear about. We say, oh, let's just let everybody get sick, get it over with. Well, the deaths would be unacceptable, but the side effects in a few years could destroy far more than just the economy.
Why are we seeing these long-term problems?
We actually don't know. We think, or we know that the virus itself infects blood vessels. There's no part of the body without blood vessels. So you could have eye disease, hearing disease, lung disease, strokes, heart attacks. So any place there's blood vessels, you have a chance of something going astray. It's going to give you a variety of side effects, and they may not show up for 1 or even 5 years.
And what are the different phases of the long-term complications and of the immediate disease? So when a person comes in and they're newly diagnosed with COVID-19, what are the different stages that they will go through, and what's responsible for that?
The way, I would preface all these comments by telling you that the only thing predictable about this virus is that it's unpredictable. But in general, when someone is exposed, 20% of the people will get infected, carry the virus, and not become sick. But yet they can go out in the community and spread it. Of the 80 patients out of 100 that get sick, 20 will end up in the hospital, and 5 will end up in the ICU, and 2 will die of the illness. That's sort of the breakdown epidemiologically. Now, what happens with the disease itself is that it has 2 phases. The first phase, as it invades blood vessels, is a disruption in clotting, so that you run the risk of thrombotic disease or blood clots. They could be in the legs, the lungs, the heart, the brain. No place good that I can think of. So for that reason, when we first get these positive tests back, we start patients on anticoagulants. A young person would often get put just on aspirin. As your risk factors increase, people use anti-clotting drugs like Xarelto or Equilus, something of that nature. And you would continue that for 30 days out to stop any issue with blood clotting. After about 8 to 10 days, the virus disappears, the immune system kicks in. In most people, the immune system helps clear the virus. But in about 5% of people, the immune system becomes hyperactive, and actually those patients end up in the ICU. While it looks like pneumonia, it's not an infectious pneumonia. It's leaky blood vessels caused by the virus that cause these unusual changes in the chest and the need for additional oxygen. That phase of the disease is the most troubling. It is the only part that we've effectively really treated, and that's with dexamethasone, a potent corticosteroid. But the idea is that you don't want this immune reaction to get out of hand. If it does, you run a significant risk of death.
So you talked about the virus having a big impact on the vasculature. How does the virus, which is a respiratory virus, get into the blood vessels?
Well, we think that when we look at animal studies, or just humans, no one's getting it by eating food or drinking water. They're getting it by breathing air. Some of the studies suggest that the primary portal of entry is actually the nose. It goes through a plexus of arteries and veins called Kieselbach's plexus, and from there gets in the bloodstream. I think probably all of us have had a bloody nose because these blood vessels are very superficial, and they're also adjacent to that ACE receptor that the virus has to bind to. So we think it all starts, we think now, and it could change, but we think it starts in the anterior to mid-nose and spreads from there.
So to keep the virus out, we hear a lot about mask wearing and
Yes.
the proper use of masks and the proper type of mask. Could you please talk a little bit about the importance of using masks and other preventive measures, including hand washing, social distancing, to try to help keep ourselves safe?
I think that using a mask properly protects other people as well as yourself. We hear about N95 masks. They're hot, they're hard to breathe through, and they're more for medical personnel. They have an electrically charged membrane inside them. They attract viruses. You may not want to take that into your house. A routine surgical mask worn by both parties is very effective at preventing spread of the disease. It must be worn properly. It must cover the nose. So when I see these people just covering their mouth, they're not protecting themselves or other people at all. They're not doing anything. It has to cover the nose. Now, they're now making a number of newer designer masks. Some have silver in them, which is very effective at killing the virus. Some have actually 2 or 3 layers of cloth, and these are also very effective. What we haven't done a good job of is getting the American public to understand that wearing the mask is a social responsibility to other people. You wear a mask primarily so you don't give the virus to someone else. Secondarily, you wear it so you don't catch it.
And what about surfaces? Initially, we heard a lot about deep cleaning, sterilizing buildings after somebody was in there. Now it seems like we're hearing more about mask wearing and more about distancing from one another. Is there any change in the thinking there?
Very, very much, and that's a good question. You know, when you have a new virus, we don't really know, did not know how it was transmitted. And an early on study looked at very high concentrations of virus on like stainless steel, doorknobs, glass tops. But you would never encounter that concentration in nature. Now that we know how many particles people exhale a minute, which is about 1 million, okay? We're paying less attention to solid surfaces. We should still wash our hands every hour or use hand sanitizer. But the main vector is droplet spread in 6 feet and airborne spread at longer distances.
When we talk about airborne spread, how concerned do we have to be if we're in an open space? For example, if we're riding a bike down the road and there's somebody up in front of us 10 or 20 feet ahead also riding or walking, if they're smoking a cigarette, I can smell that cigarette. So I know I'm inhaling what they're exhaling. How concerned do we have to be when we're outdoors about protecting ourselves from airborne spread?
The data shows that less than 1% of cases originate outdoors. The virus is not well suited to being transmitted in the sun and the wind, and it doesn't take one virus to infect you. It probably takes hundreds or maybe even thousands to establish a true infection. To my mind, being outdoors is safe. I think although the pictures of the beach look frightening, that's probably one of the safer places, and certainly on a boat or out on the water is quite safe. The closer you get to people and the less air circulation, the more dangerous the virus becomes.
What are some other more dangerous settings we can place ourselves into?
It kills me to say this, and I really love working out in the gym, but I don't go to the gym. There's too much breathing, too many people I don't know, and gyms are not set up like hospitals with negative pressure rooms, etc. They're set up to keep the exercisers cool, the people working out. So I'm very cautious about, I don't go to gyms. My favorite thing to do is eat out. Now I get food to go. There are just too many documented cases of restaurant transmission from the air handling units. A survey done about a month ago showed that they surveyed patients with COVID-19, and positive patients were twice as likely to have eaten in a restaurant. So that has nothing to do with the food. It has everything to do with air handling and external ventilation. So I think restaurants are becoming safer. I'm not sure they're there yet.
So aside from those types of high-risk environments, some of the other things we're thinking about, especially this time of year, we're getting into the holiday season. It's time to think about traveling, seeing our family. A lot of us have canceled our travel plans this year. We're hoping for next year.
Yeah.
Some people are looking for safe ways to travel this year. What are some of the concerns about traveling, whether it be getting on an airplane, getting in a rental car, staying in a hotel, that we need to think about? Are these things that we can do? Is it time to do this? Is it ever going to be time to do this again?
There is an element of good news. DARPA, the Defense Advanced Research Projects Association, for the military, wanted to know what happens when you cram a bunch of people in a plane. Okay, now recall, airplanes all have HEPA 14, very powerful air filters, really dating to 1979, when there was an outbreak of influenza on an Air Alaska flight. At that time, air went from the front of the plane to the back. Now it doesn't. Now it goes in a circle around those two seats and then through a filter. So they found that airplanes were surprisingly safe. Now, airports and how you get there, to me, are the great risk factors. I don't think I would fly to Asia on a 16-hour flight, but I would feel relatively safe, say on a 1-hour flight to New Orleans or 2.5 to New York or something. But I would wear a mask, a face shield, and if anyone around me appeared sick at all, I would put a blanket over my head and go to sleep.
Now, speaking of Asia and prior epidemics, I know you have some experience in working on SARS epidemics in Asia, which seems very reminiscent of what we're doing now. It was an epidemic and not a pandemic, but can you please tell us a little bit about your experience in Asia and how you think that plays into the considerations that we're dealing with now?
I think that's important. The last breakthrough or spillover event that was from one species to another, okay, from bats to an intermediate host to humans, was SARS-1. We have SARS-2 now. SARS-1 killed so quickly and was so dramatic that people were able to identify it, lock down the cities, and stop the spread. This virus is in the same family, but is much more indolent. With SARS-1, you'd spend about 1.5 days on a ventilator and then die. With SARS-2, the average stay on a ventilator is over 15 days, and the mortality is much less. So we have a contagious virus but it's moving slowly. The disease it causes is long drawn out. It can have up to a 14-day incubation period. And it's a virus we don't know the long-term effects of. We can prevent it very effectively by the appropriate wearing of masks and washing our hands. It bothers me, I think, that when you look at the gender breakdown, women are more likely to wear masks than men. But anyone should worry about infecting other people. The family unit is the primary unit of spread for this agent, for this virus. So I would encourage men to think of it as manly and protective to wear a mask, to protect other people, and also protect yourself so you don't take it into your household. You may not get that sick, but mom and dad in their 60s and 70s are not going to be happy if they get this disease.
So you talk about the family unit of spread, and it's interesting because we're hearing a lot about different generations among whom this virus may be spreading more commonly in some ages than others. We've got kids who have recently gone back to school. We've got people in their young 20s who seem to be not very afraid of contracting this illness. We've got elderly people who seem to be at the highest risk. Is there any age group in the population where this seems to be spreading the most rapidly? And is there anything that we should be doing about this?
Yes, an important question. If you look at Florida, the average age of infection keeps falling. Why is that? We're seeing too many cases in the 20 to 30 year age group, okay? And I understand you want to socialize, you're looking for a spouse, you feel invincible because you're young and strong. But as more of those people get infected, the more of them are going to take it home to more vulnerable people that they're around. This age group has to adapt. I mean, it's like 9/11. Everything has changed. And now, wearing a mask is a very strong social statement to me that you care about other people and you care about yourself. If I see someone not wearing a mask, I don't think they're brave. I think they're stupid. Science has very clearly shown that a mask is the best way to prevent transmission of this disease from people and to people.
Can you tell us a little bit about the way masks are perceived in other cultures?
Sure. I got on a train once in China during the SARS issue, and people were making noises and yelling at me, and I'm trying to figure out what's going on. And I realized that in all this confusion of boarding the train, I'd forgotten to put a mask on. So there it's considered a social obligation to wear a mask to prevent the spread of respiratory diseases. But yet when I walk down the street here, I've literally had people tell me, ask me, why are you wearing that mask? And I respond, it's to protect you, and that I work in a COVID unit. And that usually gets an interesting response and people leave, but it really is, the primary role of the mask is to prevent other people from catching something from you, but it also protects you from contracting the virus from other people.
Do you think maybe part of the issue is that in some of these other cultures, they know what SARS means to the population, they know what SARS can do, and maybe this being our first go-around, we don't really have that same feel for it. Can you tell us a little bit about how this SARS compares to prior SARS outbreaks that you've seen? And also, an interesting question that I've seen asked is whether this SARS is something that's man-made. Was this concocted in a lab? And
Sure.
why did China not do a better job of keeping this in Wuhan, where it apparently originated?
Sure, that's let me do the Wuhan Virology Institute first. I myself have traveled there twice. It was built to American standards, and it was built very well. There's not leakage out of there. They're not dumping viruses in the river. And also, it's 25 miles south of Wuhan on one of the worst roads you've ever ridden on. So it's not the kind of place that the tourists go visit. As far as bioengineering something like this, you would never bioengineer a weapon that you could not control and that you would not understand, that you don't understand. That would be total absurdity, and no one would do it. Finally, when you do change the RNA or DNA of a molecule, you have to have markers that tell you where you changed it. You know, there's these repeat segments of RNA or DNA have to be there to tell where that gene turns on and off. There are none of those present. This is not bioengineered in any laboratory. This is a natural evolution which was seen before. We've seen it with HIV that spread from monkeys to man. We've seen it with bird flu, which spread from birds to man. We've seen it with SARS, which went from bats to an intermediate host, probably palm civets, to people. And this natural evolutionary trend of infectious agents is going to continue. We're dealing with a huge population, climate change, which is causing different pathogens to be found different places. We have people dealing much more with wildlife, people exploring, going places, caves they haven't been before, etc., adventure travel, overpopulation, and these massive concentrations of people in a city. Like 4 million more people live in Wuhan than live in New York City. These all sort of create a perfect storm for emerging pathogens. And I would point out right now we're dealing with 2 pandemics. We still have an AIDS pandemic ongoing, and now we have this COVID-19 pandemic. So we have to have a national structure, I think, to deal with these.
Have we learned anything from the AIDS pandemic that will help us handle this coronavirus pandemic?
Without HIV, we would not have been nearly as far along with molecular biology. We're able to sequence our own genome. We're starting to know what genes do. None of that would have come about without the tremendous funding that went in to identifying this virus, figuring out how it worked, and then using those tools on other viruses.
Now, you talked about the genome of the virus, and that's something I've been hearing a lot about, is how the genes, the DNA, the RNA of this virus is changing rapidly. And is there any evidence that the virus is that there are different strains of the virus, or that the virus is changing in some way?
Yes, the virus does change. RNA is a terrible genetic material. It's not stable. DNA is the primary genetic material. RNA has a hydroxyl group on the end, so it breaks easily. A lot of the mutations don't help the virus at all. As a matter of fact, they make the virus defective and non-contagious. There is one mutation that seems to allow the virus to replicate faster, but is apparently not more contagious. But this virus could mutate at any time, so we need to keep a close eye on it.
Does it matter what strain of the virus we get infected with?
We don't know. If you were to look at New York primarily got the strain from Italy, and if you recall, it killed a bunch of people in Italy and had a bunch of renal failure. Okay? Same thing happened in New York. Okay? And I like to use the analogy of you have a bus accident a day. The people come in, but they don't go home. They stay there 15 to 20 days. And that's why the hospitals get overburdened and they need to decrease the rate of new cases. So those are areas that do worry me.
Now, talking about the genetic material, I hate to drill too much down into the science because I want to keep this something that everybody can understand, even non-scientists. But when we talk about the genetic material, it makes me also think about the different types of tests that are available. When a person feels like they're sick and they go and get tested, there are different types of tests they can get. They can get an antigen test, they can get a PCR test, they can get antibody test. And these tests are all testing for different aspects of viral infection. Can you talk a little bit about the different types of tests and what they mean?
Sure. In testing, the gold standard is polymerase chain reaction that amplifies RNA. You can measure it. It's done with a nasal swab. And it tells you the virus is there or has been there, because the PCR test can remain positive long past the time you're infectious. A second way, only used in the laboratory, is to try to culture the virus. But that's way too dangerous and is not done anywhere in Florida that I'm aware of. It's done in the CDC in Atlanta. The antigen test is not perfected yet. There are too many cross-reacting coronaviruses, and there's a number of false negatives with the antigen test. Remember, the virus can make defective copies of itself and misread copies of itself. So the antigen test might be 50%, it might not. Your PCR test is probably about 75% sensitive, maybe more done properly. So PCR is the preferred test. The antibody test tells you only that you probably had the disease. Now I say that because I know people that by every sense of definition had COVID-19 and were PCR positive, but they have a negative antibody test. So you may or may not develop a good immune response. The sicker you are, it seems the more accurate your IgG and IgM, your antibody tests are. But then again, you're looking back, like in the retrospectoscope. You're seeing what happened weeks ago. They're not of value acutely, but they are of value, say, 25 days out. You have an unexplained blood clot in your leg. It would be worthwhile to get an antibody test on those people, because if they have antibodies, you would probably want to anticoagulate them for a longer period of time.
So when a person gets symptoms or a person feels like they've been exposed to coronavirus. And from that point and going into the decision-making process of whether to get tested, what type of test to get, how to protect themselves and their loved ones, how to quarantine, and when can they go back into the general population? When are they no longer contagious? Can you walk us through that decision-making process? Because it's scary. When you feel like you've been exposed, your mind isn't working right. And
Sure.
If you think this through in advance and have a plan, it works much better. And the CDC has their recommendations, but can you just walk us through how to navigate this process?
Sure. To avoid the spread of disease, if someone has a positive swab but doesn't feel bad, they feel fine, they're just positive, they should isolate in their room for 14 days. It's that simple. Now, if someone has a positive swab and they're sick, they should isolate after the onset of symptoms for 14 days, 12 to 14 days. It varies, okay? But clearly, after about 10 days, almost everybody is non-contagious. But they add a few days on to be careful. One CDC recommendation says that if you're 7 days out or 9 days out with no fever and feel okay, you're not contagious. And that makes sense to me. For my patients, I'm a little bit more cautious. That's just me.
So when a person gets sick and they test positive for coronavirus, what type of treatment is available for that person? Whether they are asymptomatic, whether they're mildly symptomatic, or whether they're having breathing problems?
Sure. I'm going to give you John Sinnott's perspective on this. I'm sure there'll be plenty of other people that have another approach. But to my mind, the first phase is the thrombotic phase, the derangement and clotting. So if they're 18 years old, great health, not very sick, I just give them baby aspirin for 30 days. If they're a 60-year-old diabetic with lung disease or have a previous history of blood clots, in that group of patients, I'll use an anticoagulant like Eliquis or Xarelto for a month to avoid the thrombotic complications of illness. Now, thrombotic just means blood clot related. So what do you worry about with the blood clots? Well, blood clots on the brain are called strokes. Blood clots on the heart are called heart attacks. And blood clots in the lung are called pulmonary emboli. None of those are modest illnesses. These are all significant diseases. And that is the way to prevent that phase of the illness as well as we can. It's not 100%, but it is very important that it be done.
And what about drugs like remdesivir, dexamethasone, and maybe vitamins that are available to help?
A great point. Unfortunately, just 2 days ago, we got word on a large remdesivir study that we're conducting at Tampa General, and several hundred other hospitals are doing the same thing. And it turns out that remdesivir probably does not affect the course of the disease. Hydroxychloroquine does not affect the course of the disease. Only 2 agents. One, vitamin D, probably helps prevent the disease and make the course milder. So I recommend that everyone without kidney stones and with normal kidney function take 4,000 units of vitamin D a day. That's based on a British Medical Journal article on respiratory diseases in 2017. To further that, there's ample data on hospitalized patients. If your vitamin D level is low, you have a worse course. Vitamin D clearly acts on lymphocytes to help the immune system. So vitamin D, of all places in Florida, is needed because everyone in Florida knows enough to stay out of the sun, to wear sunscreen, and to wear long sleeve shirts and pants. But like I say, about 25% of people I see are vitamin D deficient. The second drug of extraordinary usefulness turns out to be a corticosteroid called dexamethasone. It's very potent anti-inflammatory, and we've been giving that with good results on our hospitalized patients with lung disease.
Now we worry about the hospitalized patient. We worry about the person who's on a ventilator. But it seems like so many patients have little or no symptoms. Is there any way that we can know whether we're at risk of being that very sick patient who's going to need a ventilator, or a patient who's going to have minimal symptoms or no symptoms at all?
Sure. What are the risk factors for severe disease? Obesity, hypertension, diabetes mellitus, vitamin D deficiency. Underlying chronic illness of the heart, lung, or kidneys all give you a bad prognosis and make you more likely to end up in the intensive care unit.
Why do high blood pressure and diabetes and obesity, for that matter, make us more at risk?
Well, in high blood pressure, you have to think of the walls of the blood vessel covered with tight cell-to-cell junctions, so you have a non-leaking pipe, a non-leaking blood vessel. With high blood pressure, you expand that a little bit, and you open up the tight cell-to-cell junctions that line the blood vessel and allow the virus to get in. And that is why hypertensive patients have a more complex, more severe disease. For diabetes mellitus, you have a thickening of the basement membrane of the blood vessel. Inflammatory cells don't get in as well. It's easier for viruses to set up shop there. Additionally, lymphocytes in many diabetics and other white cells that fight infection are simply not as active. They're all insulin dependent, and in diabetes, insulin supply is never stable.
So when people recover from coronavirus, or whether they really don't have much in the way of symptoms at all, they, in theory, will recover from that the same way as they recover from any other viral illness. They'll create, their immune system will produce antibodies that will help fight against future exposure. If a person gets coronavirus and then becomes exposed to coronavirus again, whether it's the same strain or a different strain of the virus, how will that future exposure impact their health?
It's unclear. People that have gotten sick a second time, many of them have had a very severe illness. Some have not. Again, it's an unpredictable virus. What I think worries me and makes me so cautious are the unknown long-term side effects. If I had school-aged children, I'd be very cautious about sending them to school because they might have a mild case now and in 5 years have heart or lung disease. We don't know. It's a new virus. The analogy I like to draw is when we sent patients home that we thought had recovered from SARS-1 in China. We thought they were okay. When I went back at 5 years, they were not okay. 15% were on supplemental oxygen or had lung damage. 12% needed one or both hips replaced. 8% had chronic weakness, not that much different than chronic fatigue syndrome. And a number of patients reported what they call brain fog, and we're starting to see that now in some of these COVID-19 patients. These viruses are in the same family. COVID-19 doesn't kill nearly as many people as SARS-1, but it may well likely disable more. One of the sports teams at a college had an outbreak of COVID-19, and they took those student athletes and got a research cardiac MRI, magnetic resonance imaging, a very sensitive way to look at heart function. And as I recall, even though they weren't that sick, about 30% had some changes in their heart. Whether these are permanent or not, we don't know.
So obviously we need a way to prevent this. We need a way to stop this.
The virus needs to, you want to prevent it. The treatments we have now are not treatments, they don't work.
What are some of the things that might work?
Well, it would be nice to have an effective vaccine and safe. But even if we got that, there was a survey I saw that a third of Americans wouldn't take it because they didn't feel it was safe. So if you have a vaccine that's, say, 70% effective and 30% of the population won't take it, well, we're right where we are now. People are still getting sick and dying. So we need probably an oral agent, such as used for hepatitis C or HIV, a pill that interferes with RNA replication that you could use as post-exposure prophylaxis, where you walk in and say, somebody coughed in my face, you'd get that pill, and you get the vaccine. The vaccine, I don't count on all the way. The Chinese have been working on a vaccine for 25 years. 2 weeks ago, they announced that they had a vaccine, and they vaccinated, I believe, about 70,000 healthcare workers in Wuhan, China. Now, we don't know anything about that vaccine, but we would really like to. I think for the Chinese government to use it on that scale, they would be pretty confident that it's safe, but again, we don't know.
How long do you think it'll be before we have a vaccine or a pill that we can take that will fight against this virus?
I think we'll have a primitive vaccine in the next several months. Now, how long that will last? Does it need to be regiven every 6 months? Is it 50% effective? Is it 90% effective? No one knows. There have to be large-scale studies on many different groups. You know, genetically, Asians, Caucasians, African Americans are not the same. So something that may be very effective in one group may not be as effective in another. So it's got to be a study with a diverse population, and it has to be a huge study, because if you've got a vaccine with 3% side effects, people are going to be very afraid of it, and they're going to avoid it.
How's a vaccine going to work?
The vaccines we're working on now fall into a couple groups. One is the old-fashioned standard vaccine, where you challenge an individual with a protein. That would be the spike protein or the M protein, the membrane protein of COVID-19. You develop antibodies to it. From what I know about the studies in China, the vaccines they had based on that were not super effective and faded after 6 months. Recall that natural infection with a coronavirus, and there are 4 strains that cause the common cold in humans, your immunity to that is gone in a year. So we're probably going to have to revaccinate. And over time, we'll get more refined vaccines directed against the protein. A novel approach is also being used where we're injecting people with a piece of RNA from the virus, not the virus, a piece of RNA. Once that virus is injected, it keeps making the protein spike so that you're always auto-immunizing, so to speak. That's a novel vaccine. They're in experimental trials. We think it will work, but we don't know. And those are the 2 main groups of antiviral vaccines.
If there was a vaccine available tomorrow, would you take it?
I would strongly consider it, but I would want to look and see the data on how many people it's been given to and what were the side effects. If I have a factual basis for a decision, if I can look at the data, or even better, have an expert interpret it for me and say, John, you've got 1 chance out of 100 of having a severe side effect, but you'll be immune for 2 years. Yeah, at my age I'd take it, because at 72 I don't know what my life expectancy is, and I'd like to get out and around. On the other hand, if they tell me that 10% of people have significant side effects and it's only 60% effective, I wouldn't take it. I'd rely on a mask.
So when are we going to be back to normal?
I would draw a comparison to 9/11. We will never be back to normal. I'm deeply worried that this virus will become endemic in America probably around March. And by then, the vaccine might be too late.
And so if it's endemic, what does that mean? Does that mean we have it in our population indefinitely?
Indefinitely. It's circulating like Zika is now and like West Nile virus did. Those illnesses were not severe enough to disable or kill a bunch of people, whereas this virus is.
So if it keeps spreading through our community and it's inevitable that most of us will get exposed to it, is it possible that we'll develop some kind of herd immunity?
It is possible. The cost of herd immunity in terms of human suffering, and to put a metric on it, America is a capitalist country. We use a metric called years of productive life. Okay? Using that, your life is much more valuable than me. I'm not going to be alive in a while. So my years of productive life are short. But if you have a 20-year-old that's disabled, you have to expect 50 years of human suffering and unbelievable medical expense. So getting to herd immunity, as Sweden found out, is not popular with the people that are permanently damaged or that have lost relatives. The only true way to herd immunity here would be an effective vaccine.
So we live in a society where some people, even if there is an effective vaccine, won't take it. What do you think is the reason why some people who seem very educated and have a good working knowledge of science would decide to forego a vaccine that's proven to be effective by scientists? Why do you think people would make that choice?
Why to me is sometimes almost a religious question. I don't know that there is an answer. I mean, if you had a vaccine that would stop you from getting it and transmitting it to your family or to other people, you would seem obligated to get it. I have no doubt that as this continues to affect the economy, they're going to reach a point, if they have a functional vaccine, it will become mandatory.
Do you think that can be imposed on a society like ours, where people have free will and the ability to choose whether they would accept something like that?
Well, I think if we had something like the Great Depression, 15 to 20% unemployment, a lot of people dying, a lot of people getting disabled, I think the government would have no choice but to act to protect the well-being of the country. And I like to quote, of all things, the Chancellor of Germany in the 1900s, when vaccines were first coming out, made a very important comment. He said that the health of a nation was the wealth of a nation. And if we're a nation of sick, disabled people, we're not going to be able to compete with a vaccinated country working at 100%.
Now, the economic standpoint of our country has been important. Not just our country, but our societies, our states, our local areas, and the approach that's being taken seems very patchwork. Sometimes one area will lift their mask restrictions, another area will say that you have to wear masks. Another city will say bars are closed, and the city right next door will say the bars are open for full business. How can a person make decisions to keep themselves safe in that kind of setting?
I think we have to separate out decisions based on science rather than decisions based on perhaps political necessity. I know in Florida, 80% of our state budget comes from sales tax. Hotel rooms, tourism, food, liquor. Well, all of that's not been around lately. So if we're going to pay the bills, I can see the political emphasis on opening up. On the other hand, the idea that this disease will rebound is very real and could be far more expensive than what we're dealing with. I was talking to a statistician that showed me that if we had locked down for 3 weeks in March, we would not have this now. That simple. We wouldn't have the economic issues. We wouldn't have these massive outbreaks. 760,000 citizens of Florida, 17,000 dead. That's not right. There needs to be a clear message. I feel the message should be uniform and it should be federal. And that's essentially what they ended up with the great influenza of 1918. It essentially ended World War I, and the government just decided this is killing too many people, it's using up too many of our resources, and everybody's going to wear a mask and isolate.
Now, it seems like this virus seems to be moving and spreading through population in waves, where we'll see a spike in numbers and then it'll reduce, and then another spike. Is there any sort of thought process behind that and how that will look in the future?
It seems to be associated most with wearing masks, adherence to that. And there's a great example. I like to use the great influenza because everyone knows what I'm talking about. But Minneapolis and St. Paul, I've been to both of them. I can't tell them apart. And I can't remember which one did what. But one of them mandated masks and the other didn't. The death rate was 10 times in the non-mask wearing city. And after a while, they had riots where they demanded the government make them wear masks. So I would also draw an example for cruise ships. The Diamond Princess did not have masks. 80% of the people that got off that boat had COVID. At the same time, there was an Antarctic ship that set sail out of Ushuaia in South America, but they had an idea what was going on, and they mandated the wearing of masks outside the cabin and that you would be served food in the cabin, okay? They had an outbreak of COVID. Less than 20% of people were positive. And because they had such lower inoculums of virus, I don't believe any went to the hospital. Whereas on the Diamond Princess, they had a number of deaths.
Now, I'm glad you brought up cruise ships because, we are a boating club. And one last question I'd like to ask before we conclude tonight, and you've been very kind to spend so much time, not just tonight, but for the months and months that have led up to this, helping us as a club stay safe. One last question I'd like to ask is that as boaters, we like to get together with other boaters, whether it be cruising or hosting big regattas. And given that we know that some areas of the country where competitors or where cruisers may be coming from may handle the situation very differently than we do, right now we're hosting events that are local. How long do you think it's going to be before we can safely host major events where we bring in people from around the country and maybe even around the world?
I'm working with Mr. Pennington on that now. And I'm going to use, loving boating as much as you do, I feel very safe on the boat. I think they're great. We put together for the Florida Institute of Oceanography what we require before you go on a cruise. Now, these vessels are not well aerated. People are close together. We have them get a COVID test 3 days before they go on the ship. Then we put negative pressure throughout the boat, and we encourage people to sleep with their windows open, sleep out on deck, but don't crowd around the dinner table, and we haven't had any infections at all. So I think that probably if we use these guidelines, and if people will follow them, we could start soon. But again, the people going on these ships are scientists, and they understand the reason. They get the reason. You want COVID? No. You sleep out on deck.
Well, we want to get back to racing. We want to do it safely. We want to get back to cruising with our friends. And hopefully that motivation will help us to stay safe. And again, I appreciate all of your help with this. Do you have any questions for us as a club?
I want to let people know that all of us here, our hearts go out to people that have been affected by this terrible disease. It's unfair in who it makes sick. It's unfair in its outcomes. We're counting on American science to come to the rescue here. I urge you to listen to what the scientists say and not the politicians. Thank you.
Thank you. It's been a great pleasure talking with you tonight, and thank you all for joining us.